Good afternoon, everyone. My name is Nancy Del Mastro, Project Manager at Adirondack Health Institute. On behalf of the North Country Telehealth Partnership, a joint effort between AHI and Fort Drum Regional Health Planning Organization, we're happy to provide this educational webinar brought to you by the Northeast Telehealth Resource Center and UVM-HN, or University of Vermont Health Network. And we'll be hearing from Reid Plimpton and Chris Gilding on building connections digitally, considerations for optimal telehealth practice. They have a ton of really great information to share with you. So without further ado, I'll turn it over to Reid and Chris. Thank you.
Thanks, Nancy. And thank you everybody for being here. To her point, I think we have a decent amount of content. I'm really excited to sort of let Chris get to his and then also hear your guys' questions. So I tend to talk fast as always, but I might talk a little quick through some of my sections. I will call out that you'll get these slides and access to this recording after the event, because a lot of the stuff that I touch on, there's resources linked within, so on and so forth. So where can you go from here? I think that's the overarching question these days, right? If you're coming to this for policy, I definitely glossed over that, although I didn't provide a lot of really important links, and the timeline as we currently understand it within the appendices, the sort of the resources section of this document. We really focused in on what the title of this is, right? Is like, how are we practically applying telehealth for our patient population, for our organizational structure, so on and so forth. And with that, I think the structure of this is I'm going to kind of go a little bit theoretical and tips and tricks for considerations. And then Chris is going to hop in and get really practical with you guys. And so with that in mind, the only other thing I'll add is that this is your time too. Really grateful that you're giving it to us to join, but please feel free to chime in wherever. It's easiest, I think, to have conversations and answer questions about the topics right when they're at hand, rather than to try to, revert 20 slides later. So whether it, using some sort of raise your hand feature or unmuting or using the Q&A, feel free to just chime in whenever. If you're not familiar with us, the Northeast Telehealth Resource Center is a federally funded grant through HRSA's Office for Advancement of Telehealth. And we have two sort of arms to us. A lot of us are housed within MCD Global Health, which is a global nonprofit. And some of us, like Chris, are housed within the University of Vermont, the Health Network, and the Medical Center. There are 14 TRCs across the US. I think the easiest way to sum up what we do is that we're here to help. Right. All HRSA grants are sort of aimed at increasing the access to care and increasing the quality of that care for the rural and the underserved specifically, but for the general population. The Office for Advancement of Telehealth grants are given the added auspices of increasing the understanding and utilization of telehealth. And so that really does boil down to, we're here for it. Whatever question you have, whether you're a patient, a consumer, or a health system, you name it, reach out and we will do our best. You can see the geographic spread here. What is telehealth? I'm looking at a lot of the names here. I'm looking at the organizations that I saw in the registrations. I think I'll be pretty brief here, but I do want to just kind of make sure we're all in the same framing moving forward, in the sense that it is not a new arm of medical care that now needs to have all these paradigms beneath it, but rather it's meant to sit within all the current healthcare structure, with all the current clinical care avenues and specialties and so on and so forth. And it's a tool within your toolkit. There's a ton of terms out there. I think telehealth and sort of digital health are the two most broad encompassing, and then you can get more specific within there. If you are a policy wonk like myself, I think that the distinctions here are really important for you, and that's also true for any financial folks that are on here. And this is the sort of the buckets as defined by federal steps and state statutes. So video conferencing, synchronous interactions, it's what we're doing right now. Asynchronous interactions is sort of what it sounds like, right? It's a non-real-time encounter. It can be notes, patient files, it can be photos, so on and so forth. And that's sort of bringing a clinical specialist or, somebody else is sort of unavailable for an immediate visit in for consult. Remote patient monitoring differs in the sense that this is a device that's usually attached to the patient, has some biometrics attached to it. Pre-COVID, I'd say the main the most popular two avenues to utilize this within were within the chronic care management codes, and the existing structures for that, and within, outpatient follow-ups, and things like that. So you're getting sort of more frequent biometric data and information from the patient to help you inform, their current diagnostic state. And then, excuse me, mobile health differs again in the sense that that's biometrics that are available to the patient that you may be grappling with, right? Like whether it's an any of the wristwatches, a cell phone, or anything like that. But that's a device that is uniquely direct to consumer, that's sort of new to the world. I think FDA is where I would watch most closely if you're interested in that realm. And then peer-to-peer, again, we're talking like policy. Definitionally, this is different in the sense that there's not necessarily a patient present, as the government defines it, like in the sense of e-consults, or just in general, like a Project Echo. And so that's that's a clinician to clinician, or a medical professional interaction, that may utilize any of these other four buckets, but definitionally it's its own thing. So that's the sort of landscape that we're talking about, right? And so then you talk about the emerging considerations. I personally find this time period really exciting. It's because there's really obvious considerations for everybody involved in the equation. And therefore, if everybody, shares their stories and experiences and we learn from one another, we're going to have a really great possibility of telehealth landscape at the end. But I mean, with providers, it's not as simple as just getting them the software. There's a lot to consider, right? We've got workflow, we've got licensure considerations if we're talking, potentially geographic, like on the borders. You've got other considerations around that, whether it's supervision and so on and so forth. The evolving policy, that's the round door, right? That's something that we're not touching on today, but it's a part of it. With the training and integration of these new softwares into what's already a pretty time-strapped environment, that's all real, and trying to figure out how to best do this is a part of that. But on the other end, the patient's piece of this is new. A lot of it's new as well, right? Like historically, you haven't been able to deliver any sort of consistent video visit or other care to a patient's home unless they're a very specific population, like chronic care management for remote patient monitoring or whatever. And so that there's this whole new litany of things. And so we're talking about, accessible care for, the blind, deaf, hard of hearing, or otherwise disabled, whether it's intellectually or so be it. We're talking about language considerations, digital literacy, who's available for the tech support. And then there's this bucket in the middle. But knowing all of that, I think, is a lot, right? And that's why you're all here. But also acknowledging all of that makes it so you can make kind of concrete, actionable determinations, right? If you need translations available for a large percentage of population, that is a huge lift to make sure that it's fully integrated both into your video visit interaction when you're adding the translator or the interpreter, and with the scheduling and so on and so forth. So make that your priority, right? Like that is an action item that you can take. And so when you look at the Venn diagram, if you can then find something that makes sense to you, it's more actionable, right? And so I guess another bucket would be etiquette. I think the reason why I felt this was important to call out is HIPAA considerations go back into effect May 15th, right? When the public health emergency ends on May 15th, the Office of Civil Rights will no longer have their sort of currently relaxed oversight around HIPAA. And so that now we're talking about, is it a secure room on both ends? Is it headphones if the provider's not in both ends? What is the placement of virtual backgrounds in this scenario? There's a lot to sort of grapple with, but there's also just interactional and interpersonal aspects to this, right? Like my teletech etiquette is pretty awful. I talk too fast. I usually wear contrasting backgrounds with the wall, or clothes with the wallpaper that I've got going on behind me. Big hand talker. But that would affect my patient encounter, right? And so like just thinking about your provider trainings, and how to weave in some of these considerations, it's a really practical way to kind of integrate telehealth, right? The tech considerations around wired internet may be important if you're going to have more than one, or depending on the size of your facility, 5 concurrent video visits, right? If a bunch of providers are doing check-ins at 11 o'clock, you might want to make sure they're hardwired. I don't know how strong your Wi-Fi is, right? Like that's stuff to start thinking about. And then obviously the daily routines of, are they at home doing these video visits? Are they on site? Like you can start to integrate all of that. And the etiquette is a piece of every piece of that puzzle. Pre-telepractice is a phrase that Dr. Tara Rabinowitz at UVM uses a lot, and I like it, so I often steal it. And this is more about like a virtual site visit. As we become sort of more routinized in our telehealth processes, if you're doing something like, so Terry does a lot of work with long-term care, long-term care facilities, and where the patient's going to be in sort of the same place every single time he talks to him, and he's going to be in the same place every time he talks to them. So then he can do things like, what is that room going to look like? So I know, right? Like if a patient falls to the left and it's off screen, I know that, oh, there's actually something over there. I might need to call and have somebody check on them, right? Like he's working with the elderly. That's a consideration he has to take. But you can extrapolate that out, right? Like, I know in New York, there's been a lot of work around libraries and other sort of, community access points. You can talk to the staff there and understand what that facility is going to look like, what that room design is, so that you're more aware of what the patient encounter is other than this little box you're seeing. But you can also understand the Wi-Fi considerations, the broadband considerations, so on and so forth. And then the safety issues pieces of this, right? Like getting back to HIPAA, part of your patient encounter is knowing where they're at in case you have to call 911 or some other sort of emergency protocol escalation. If the patient's going to be in a consistent place on the other end of the video visit, you can sort of extrapolate that out to highlighting, who is the staff involved. Swapping gears here, and this is the part where I'm going to go kind of quick because I want to make sure that Chris gets to talk to you guys as well. When you think about your community, your patient population, the folks that you serve, I think there's two things to keep in mind here. Which of these questions apply to you and where are you integrating them, right? Like the 15 to 20 minute encounter that your clinician is having with your patient is probably not the best spot for most of these questions, nor is I think it feasible to say that you're going to go add 6 more forms to your intakes or whatever, but there's spots where you can get some of this information, whether it's from the patient directly or from community organizations around you that already kind of aggregate this. But we're talking digital literacy and we're talking digital access, right? And so, what is the digital access for them? Do they have a phone? Do they have, a tablet, a 3-screen setup like I've got going on here? What is their access point? And then next, what is a reliable internet? I think at this point, I'm running into about a 50-50 split of those who completely know what I'm going to say on my next point and those who are like, oh, I've never thought about that. But if they don't have reliable internet and they're thinking about potentially having to use their data plan on their cell phone to do your video visit, you're asking them to give up the month of data. Like that is a huge packet of data that you're asking them to commit to you, and that could be a huge piece of why you're having video visit no shows or whatever it is, because it's a huge thing to think about. And if they're unfamiliar with telemedicine, no, that's a consideration, and maybe we need to be doing in-person visits where we can get them some resources or whatever before we try to dispatch them to video, checkups and follow-ups. But it's also think about with their tech familiarity, right? If they've never done a video visit before, like asking them to commit to it on a cell phone is entirely different than asking them to commit to it on an iPad, which is entirely different than asking them to commit to it on a desktop or a laptop, right? And so like those are things to think about. Trust and confidentiality, I think that's a huge cultural component to it, but also just patient experiences with healthcare in the past, and also their current reality, right? Like as nice as my tech setup is, I am kind of in the middle of the hallway upstairs here. I've got 2 kids downstairs, so I have no guarantees as to if we've got any guests showing up here. And if you're doing certain clinical encounters, the privacy of that is a huge piece of it, right? Like Dr. Rabinowitz has some really fascinating threads on like safe words that he's come up with for some of his, mental health patients he's working with or potential domestic violence patients, just because they're in open spaces. And so just being aware of all that before you get into anything else is sort of the overarching headspace I'd be in. And then this is something that I think Chris and UVM can touch on as well, and they've done a really great job of helping me understand it concretely, is you can start to come up with inclusion and exclusion criteria that you can then adapt and develop over the next few years, right? Like, I think if you start clinically focused, it's a little bit easier, patient focused, because of the way I brought it into it, right? So we just talked about their access points. There's determinations there as to whether or not a video visit's appropriate for the patient at this point in time. Talked about their literacy. There's determinations that you can make as to whether or not any telehealth encounter is appropriate at this point in time. Broadband access, so on and so forth. And so that can be little notes in a patient file or things that you routinely check in with them on that help you understand where they fit into your portfolio of in-person, digital, and hybrid encounters. And then the other side is a little bit easier to see right now, right? Like you've got 3-ish years of provider experience of integrating telehealth. And so you have some kind of concrete provider experiences, and there's plenty of concrete data coming out around like what is medically appropriate for telehealth encounters. There's some that's vague, but there's a lot that you can concretely use, right? When do you need to get your hand on your patient? And you can go through that. Payer coverage, I'll call that out just quickly. Hopefully, we don't have to linger on it for too long, but there is variation afoot, I will say, between the various different insurance plans, whether it's federally, state, or private payer. And so being aware of that's a piece of the puzzle, especially if you are a system where ROI is important at this point in time. Compliance, licensure, all of that. And so you then sort of have this, this two-fold list of things that you can use to help inform when you're triaging your video visit. So it's not as though every patient and every patient you see within your health system can go get a blood pressure cuff tomorrow. And now all of a sudden you've got all this blood pressure data to deal with, right? It's a very different world than that once you get to this point. And I think it's a helpful way to sort of think through it. Once you know that you're going to have a telehealth encounter with a patient, now you're talking pre-visit, right? So you've already scheduled it. Patient outreach, however you're doing that, there's ways to weave some of what we've talked about in here. I've linked a video here that you are more than welcome to use, but also sort of helps you think through some things. And then I've got some bullets on that. What's the actual encounter going to look like, so on and so forth. The tips for starting the visit, again, this is another thing that I think Chris touches on a little bit today, but I also have learned a ton from UVM on, so I'm going to defer to him on. But the starting the visit is not as simple as like, oh, I scheduled it 3 weeks ago. I'll see you at 11 a.m. Right? There's a lot of steps in between there, and sort of getting concrete and really granular about that. The more granular, the better. But then on the other end of that coin, the more concise and clear for the patient, the better, right? But really thinking through what you need to be clear with them on in order for them to be able to be there at 11. Post-visit considerations. I think this is an interesting piece of it. A, just because everybody's sort of experiencing it, right? You always end a visit, but B, because there's a lot of information that can be gleaned from it. And so, there's the stuff on the left that I think you're sort of legally and regulatorily obligated to ensure you're doing. To just get serious about it for a second. But then there's the stuff on the right, where you can can inform everything that I just blabbered on about for 20 minutes. You can get information from your patients. You can get information from your providers, and so like as they exit out of that video platform, the majority of them give you a way to put something else that happens next. You can force feed a survey, if you will, so on and so forth. And so there's a lot of information, in my opinion, that can be gleaned from there that will then further inform your integration of, telehealth interactions. Most of these taking a breath, but hopefully, well, I was. You guys were looking through all these bullets. This section, I think it's kind of one of the last before I hand it over to Chris. But I do want to call out that there are a lot of questions unanswered, and people like you are really important for us to help answer them for the masses. But I also want to call them out because I think that if you're not aware of the fact that they might potentially be also wondered about by a lot of people. It can get daunting right now, right? But there's been 3 years of, with the first set of public health emergency waivers, the phrasing was the Wild West of telehealth. And like that's been 3 years now. There's a lot of stuff that we weren't doing before that luckily we're going to be able to do now, right? Like luckily we found enough support and data and experiences and interactions that say we should be able to do this. But that means that we still have stuff to iron out. And so knowing that, I think, hopefully helps you with your provider interactions, but it's also important to call out with the patients, right? Like getting back to the slide before this, where I'm talking about patient feedback. I think to me, it's more validating if you're like, no, we, part of the reason why we're asking you these questions is because, we haven't before last year had the opportunity to do a video visit with somebody who's hard of hearing. And we want to make sure this is the best video visit it can be for you. Like just acknowledging we're all in this space of like, this is pretty new to be able to do video visits the way that we can, to be able to do RPM the way that we can, so on and so forth. And we're trying the best we can. We're learning together. What do we do about all these things? I think it's hopefully you guys are all telling me that soon. And because the next step here is is equity ideally, right? And so how do we address that? It's being aware of the questions that we all need to ask and trying to find the concrete range within them, right? Like I've got broadband availability on here because I think that it is possible to rightly assume that the millions in dollars that are flowing federally for broadband expansion will solve our problems. It's also possible to rightly assume it won't because the need was vast. And so like we're going to need to continue to kind of concretely be able to say like our patient couldn't do this because they dropped off an audio call 4 times in a row. And so now we need to elevate it or whatever. But also, give sort of figure out, do we need hotspots? Because there's sections within our community that we just know can't get the access. Things like that. And it's not just you good natured people that are wondering this, right? There is people at the federal level that are acknowledging that like, hey, this is something that we're supposed to be doing. We're committed to it, and we want folks to start thinking about it, right? And so accessible telehealth, broadband access is only a piece of that. I've talked about disabilities a few times, and I think it's because it's sort of one of the things that needs to be lifted up over the rug in the next few months, in the sense that like even if we are all doing telehealth comfortably, there's a lot to learn for folks that maybe could do it. And so DHHS has started to produce a lot of guidance. We've been lucky enough to work with the regional ADA center in our region and a few of the other TRCs to kind of start to get concrete about this. And so this is a section that I really do intend to kind of fly through, but I'm calling out for you guys to be able to come back to. And so it's sort of, I think it's 10 tips and practical recommendations for considerations around making sure that your telehealth opportunities are as accessible for your patients as they could and should be. So inventory, assistive technology, consider the patient's structure around there, develop the understandings, and then make sure that you have an avenue for accommodation requests. Again, like all of this is here for you guys to come back to. But I do think it's a really big, it's a keystone of the next few months to me. Effective communication. This is something that if this is something that applies to you, hopefully you're able to take and use, but it's just thinking through what it looks like if after you've done these practical recommendations, you identify a few patients or a subset of your community that needs assistive support, but is still capable of doing the rest of the telehealth encounter. How do you do that, right? So examples of auxiliary aids for both populations. And then tips around not talking as fast as I do and providing other professionals that maybe can assist you in the communication of that, alongside tips with documentation and other reference material interaction, right? Like making sure that the medication you're prescribing is large enough text to be able to read the potential considerations around it. Yeah, and so the reason why I call that out is A, because it's vital, and B, because I think the other next step that I haven't really touched on yet is quality improvement, right? It's potentially a huge piece of why you are here. It's an underwritten piece of what I just talked about. And again, it's another one where the federal agencies involved have at least indicated that they're really interested in and in helping inform the long-term path for telehealth implementation. And so, what's included with that, and how are you integrating the aspects of social determinants of health as they're predefined? I do think there's an avenue of conversation around digital equity and digital literacy, either being its own pillar within social determinants of health or being, further integrated within the pillars. But as it currently stands, the latter structure, the latter point of being further integrated into the pillars is sort of what I'm suggesting to you all. Is that you're probably already conceptualizing this for your community and for your patients, for the social determinants of health conversation. I mean, so it's not a huge leap for you to take some of what I've just given you for insights, and place them into this conversation where you're already giving it air, for your system and for your community. Last thing here, just remember, I mean, I think primarily, although I can't speak for all of you, but primarily you've likely been just doing video visits, whether it's through a monitor or through a laptop or other device, for the last 3 years. And the telehealth tech landscape is vast and it's growing every day. I'm personally one of the thousands that'll be at the American Telemedicine Association later this week, their annual conference. And I think the last time I looked, there was over 600 exhibitors. The landscape is huge, and the reason why I call that out is just be really careful, as not really careful, be really cognizant, as you're thinking about how to integrate the digital landscape into what you do and how you do it. Are you fishing or are you hunting? Right. When you're fishing, you're kind of just tossing out some bait. You're like, here's what I'm hoping to catch, right? But you'll take in whatever you get, and whether you keep it or not, it's up to you. But when you're hunting, you know what you want, right? Like, you're going out there, you're looking for a specific thing. You got a plan in mind, and I call that out because I think, like I said, every day you're seeing new stuff pop up, and the reality of mergers and acquisitions and all of that. Pre-COVID interoperability between tech software and tech hardware and EHRs and all of that was a huge name of the game, and I think it will be post sort of COVID public health emergency as well. And so just calling that out, right? Like just being really aware of what you're looking for, as you try to build your hybrid sort of portfolio. And then this is just sort of a cool thing to keep you guys invigorated for the rest of your week. Dr. Bertolon Mesco, who I will call out, is in a very different sort of healthcare structure out in Germany, sort of has drafted this up. And this is the land of digital health technology integration is the way he sees it. And so, going back to my previous slide, like if you came into this presentation wondering, like, do I think video visits will be a piece of my healthcare system's efforts in 5 years? I personally think the answer is yeah, definitely. What else can you do? And so that's where a lot of what I just sort of went through came from. And yeah, tips to get started, find a champion. It's probably you, right? You're here on a Tuesday afternoon, listening to me, and then just make some really actionable strategies after that. And with that, I'm going to hand it over to Chris.
Thanks, Reid. Hi, everybody. My name is Chris Gilding. I'm a telehealth program strategist with the University of Vermont Health Network. Work very closely with Reid on a multitude of different things. So if you have any questions about anything really telehealth-wise, he's probably a good go-to. So today I was hoping to go through some of the things that Reid discussed in practice. What does it look like? How do you actually make this happen? And it's something that we've been doing. We're right in the middle, actually, of a third phase of a MyChart televideo rollout. So what we're trying to do is we're trying to integrate. Go ahead, Reid, click on that for me. Thank you. So we're trying to integrate Epic and MyChart with our televideo visits. So previously we had utilized Zoom only. So now we're working within Epic to make sure those Zoom links go out to patients, and it's all done right within the MyChart app. So we had to bring in a lot of different team members to kind of make this happen. So like I said, we're right in the middle of our second phase of rolling this out. And just to give you a little bit of a background on what kind of numbers we're looking at, how many practices, that sort of thing. So we're right around 93 practices I think we've gone live with to date. So we've had a lot of volume, and it's been a really good opportunity for us to kind of learn from our mistakes and identify problems as we kind of phase a rollout, to make sure that we're meeting our customers where they where they are, whether it's internally within our network, our employees, or our customers, our patients. So we took a bunch of different teams together and kind of put our heads together. How do we make this happen? So we included everything from patient access, patient experience, the digital health services team, which I'm on. It's a small team, but it's pretty mighty based on some of the numbers we're able to turn over. So it's been really good. And like I said, we're just trying to integrate Zoom within Epic and MyChart. And basically, in a nutshell, what that means is we're just going to have a more efficient experience for patient and the care team. So the way patients are actually getting into a televideo visit is changing. The way it's scheduled makes it a little bit easier on our scheduling staff. So we kind of look at it from a lot of different areas of this is going to improve the whole situation for everybody. Like I said, we've kind of broken this out into 6-week implementation timeframes, and that we feel like, given that all the information that we kind of have to go through and identify, that's a pretty good time frame. I'll get into a little bit of the planning and the build and what that really looks like as we keep going. Next slide, Reid. So again, for those who aren't familiar with MyChart is the basically the patient's front door, the digital front door to their care. So they're able to message in MyChart, they're able to review labs in real time. So it really provides a good opportunity for a patient to be more involved with their care, and also a little bit more able to communicate directly with their practice. So we've had a lot of different utilization in this, and hopefully we're getting to a point where we can really market MyChart to our patients as a way to really stay connected to your care a little bit more closely. So it takes a little bit more off the patient to have to kind of guess what's going on, or how did these labs come back? What do they look like? And again, it opens up that communication between patient and provider. So there's a layered approach, and I'll kind of touch on this a little bit towards the end of my slide deck here, but we have different layers that we're trying to get through, and this MyChart implementation is just one piece of the bigger pie. So it's an important one, and there's a lot of work that goes into it. And with that, you have to really make sure that you have all the right team members at the table to begin with, to make sure that you're kind of vetting out all these ideas and what stumbling blocks you might come up with. Go ahead, Reid. So this is more just for a visualization of what we're trying to do. So the major role of my role in this whole rollout is to keep teams on track. So between three kind of program managers, we have between 11 and 15 practices at that 6-week clip. So it's a high volume. Obviously, you're going to have different practices utilize telemedicine and televideo a little bit differently. You might have a primary care office that's a high usage, so you have to take that into account in your planning phase of everything that goes into that. What is your scheduling workflow? What do you do differently than, say, a general surgery practice that might not use televideo as much? So you have to kind of take that into account as far as where is your training, how often are people going to be using it? Because we've seen that if you don't use something very frequently, it's going to take some dusting off and kind of get used to a little bit, getting back into the workflow. So this is just kind of a screenshot that I wanted to show. And the big thing, and I think the biggest lesson that I've learned through this is just be flexible. You have to be flexible to adjust your workflow to the practices you're supporting and be able to kind of meet those practices where they are. Because like I said, you're going to have a wide range of operations happening at different practices, that you might need one practice that has an autocomplete feature turned off within your EMR, just to make sure that follow-up is happening from the scheduling side of things. And there's all these different things that you kind of want to make sure you're at least on your radar. You don't have to necessarily have the answers, but if you know the right questions to ask, you can kind of formulate a practice's full workflow to make sure you're avoiding those pitfalls. So like I said, we're changing over, my bad, Reid. We're changing over to the MyChart televideo types, and this is what it looks like. I wanted to put this in here for what does a patient see? So they can access it either through an internet browser or through their mobile application. And that's another thing. I like this slide deck just because it kind of formulates everything in order. You have to really, like I said, meet that patient where they are. Some people don't want a new app. They don't. Their healthcare is scary to them. They might, technology is another stumbling block, something like that. some people might not want another app. So if you can meet that patient where they are, and part of that is empowering your scheduling staff to have that conversation and to understand where that person's coming from. I totally get it. You don't want another app. I understand that. Can I have a second just to kind of explain it to you in a way that I can show you some things that it might be not be so daunting? How can I help get you where you could go, or maybe not? You know, like I said, some people don't want another application, but just meeting them where they are is really the name of the game. Go ahead, Reid. So again, this is just a brief timeline. We're coming up right now actually on our go live tomorrow. So we've been working, we tried to break it down as digestible as possible. And there's a lot of work that goes into each one of these weeks, but we kicked off in the first 2 weeks, we really wanted to hone in on scheduler training, just because the schedulers had the biggest lift in this, the biggest change in their workflow. It's an easier workflow in my opinion, but it's still a change. So that's another thing that had to really go into the program planning and understanding. We're putting another thing on a scheduler's plate. We're asking them to make another change. So how do you meet them where they are and understand, hey, I'm asking you to do something more, but in the end, it's going to be easier. And I completely understand another change is another change. So understanding that mindset of your staff is going to be vital to success in this, because as we all know, you're only as strong as your team members. That's really all I can say about this. Is without that strong team atmosphere and able to adapt and the ability to kind of see through the forest a little bit, that's been huge for the success that we've had here. And then clinical training was put more to the later stages, just because it was just a little bit smaller lift. And I think the biggest thing that we really needed to tackle was understanding what volumes your practices are having for telemedicine visits, televideo visits, and what does that mean downstream? We had to convert all of these appointments that were previously a televideo. Now we've changed it to a my chart. So in the build, everything had to go through all the different teams for that. But the big piece was being able to get ahead of it and speak with patients, because they were going to have a different link. So the link they might have had 6 months ago for a March 4th appointment is going to change. So go ahead, Reid. I think I touched on the next one here, but so being able to have that conversation with patients, and I touched on a little bit earlier, but empowering your staff, your practice supervisors, your scheduling staff, whoever it may be, to really feel comfortable with this workflow and start from the ground up, because the more empowered and comfortable that folks feel with workflows, the easier they're going to be able to talk to it about it with patients. And that comes up big when you have a patient that is reluctant to change. I don't want another app, you know. You need to be able to have confidence in your staff feeling comfortable with workflow. So we had a lot to do. We had to get every user from different practices, whether it's an operations support specialist or a scheduler, whoever is going to be really touching this process. We want to know who they are. We also wanted to designate a super user, the boots on the ground that I can meet with every week and say, hey, how are things going? What are you seeing from your staff? Just kind of that conduit of communication, to make sure that you can identify things that are, when they break in the moment, who's that go-to, that person in the practice that you can say, this person knows this cold, and help troubleshoot, and if not, we can at least escalate it to where we need to go. And like I said, it's been an ongoing learning process in this whole thing. We have to verify clinic hardware compatibility. So we had a lot of people using devices that either were personal devices for video visits, or they were using iPads from the network. So they were network managed devices, but knowing what that looked like has been a really big step in this process. You have to know what you're dealing with. What configurations do you need to make sure are updated? What apps are pushed? That's been a huge thing for us, is just kind of upfront, tell me everything about your practice. What's your workflow, but also what are your devices and how do we mitigate some of those problems for security reasons that might come down the pike. We utilized a team chat for Go Live. I found that's been really helpful, just because it gives everyone, and again, super users, practice supervisors, all of your people in the know could be on this Teams chat, during a go live type situation where you can bounce ideas off of each other and really try and flesh out some of the details. And it's quite often that you'll see one problem in one practice is going to occur in another one. So how do you kind of get that together as far as making sure you're avoiding that kind of situation? Yeah, go ahead, Reid. So from the project management side of things, my biggest role in this whole process was making sure things stay on schedule, connecting the various parties, from different teams to make sure that the work is getting done. Also an escalation point for any type of like appointment conversion issues. It's kind of like a can of worms. You think you know what you're going to be looking at for problems, and then it just kind of peels back more, and that's part of just being agile and being able to adapt to some of the issues that you might be having. Go ahead, Rob. Practice leaders were absolutely integral in this piece. There's not a better person to understand a practice than the practice manager. They're going to understand their staff. They're going to understand their workflows. They're going to be your primary point of contact. And really, it gets you down to that next level of, okay, who's your super? You're the practice supervisor. You might have a larger practice. Who's now your super user? How do we get everybody on the same page so we're disseminating the information in an effective way? Make sure everybody feels comfortable being able to be available for any questions or things like that. So practice leaders are just, they're worth their weight in gold. Next slide, Reid. So things to be aware of, and like I said, this is an ever-growing list. We find one issue, and then at the end of the process, we find 3 more, and we get a little bit better for the next time. So key things that we had to be aware of was training. We had to develop a training that was effective and easily disseminated. So we worked within our Cornerstone system. Cornerstone's a training module that we used, and it goes back to that team aspect. We had to bring in education up front to kind of understand the problem and then develop ways that people can learn from it. And so we've created, it's probably a 3 or 4 minute video, not too big of a lift, that we sent out to every person that we got on those user lists, received it, whether you were clinical or whether you were administrative. Like I said, we broke that up into two different kind of chunks, just to make sure that we could keep an eye on who's completed training, what numbers do we need to report back to practice supervisors. Hey, Sandy hasn't done this. Can we make sure we get that done, just so everyone's on the same page? And we found that it could be as simple as just adding the wrong column within Epic, our EMR, can really derail us. So it's that little thing that just pay extra attention to the fine details, because they could be small, but they could mean for big problems down the road. And again, the personal devices, we don't support, our teams don't support personal devices, but that doesn't mean providers aren't going to use their personal devices. Of course, they're going to, if it gets them to the patient, I look at it like, and it's secure and it's safe and everything, I think it's fair game. Although we might not support them, we can at least help them make sure they have the right updates and everything like that. So really huge takeaways for us that we just continue to learn from and iterate for the next process. So hopefully, the 5 problems we identified in this go live, that we're going to be ahead of the game next go live. So just continuing to iterate on different processes. Go ahead, Reid. So this is a little bit small, sorry, but really, and I wanted to touch on this because it resonated with me, that although you have your big project, it's also, if you zoom out, it can be a huge win organizationally to open up other doors. So we've started e-check-in where patients can check themselves in, and this MyChart video visit is just part of that, kind of the patient self-service experience that we're trying to launch, and give a little bit more autonomy to the patient in their care, let them control it a little bit more. And like I said, it's just one chunk of the bigger goal. But yeah. Next slide, Reid. Any questions I know covered a lot there, but I'm happy to answer any questions, anything that you might have had going over that stuff.
Hey, Chris, thank you. I don't see anything in the chat yet. But again, to our participants, attendees, feel free to unmute if you have anything you want to ask directly. Otherwise, you could feel free to place any questions in the chat for Chris and Reid.
While we're waiting, I will just sort of briefly click through the sort of appendices that are promised so you guys know what else is in here. That would be it.
I was just going to say, everyone, you'll be receiving the slide deck, a ton of amazing links, resources for you to review, look into integrating into your practices. So again, the recording and the slide deck will be sent to you all in the next few days. I know that sometimes attendees will private message presenters, so you know, Reid, Chris, if you do see anything on your end, you might want to check quickly. Otherwise, nothing else on my end in the chat.
Not seeing anything over here. I will just reiterate, thank you all again. Hopefully there are some nuggets to act upon. And yeah, I always feel free to reach out, whether it's with questions or with success stories. We love to hear the cool stuff that folks are trying to tackle and, you know, take on. But yeah, I don't see anything, and so I'm happy to give people 10 minutes back in their day. If they don't have anything, I'm also happy to stick around right up till the top of the hour if people are waiting for questions.
I do see some folks starting to jump off now. I want to thank everyone for joining us today. Thank you so much to Reid and Chris for this amazing presentation and for all of the resources you added for our participants. We'll keep it open just for another minute or two if there are any questions that come through. Otherwise, have a wonderful rest of the day and the week, and always feel free to reach out to myself, Reid, Chris, with any of your telehealth needs.
Thank you very much. That was excellent.
All right, I'll go ahead and close it out. Thank you, guys.
Thanks, Nancy.